Well, welcome everybody. My name is Carolyn Dubé. I'm the Executive Director at Fertility Matters Canada, and I am thrilled to be with you tonight celebrating Canadian Infertility Awareness Week with Dr. Beth Taylor from Olive Fertility in Vancouver, British Columbia. Olive is a huge supporter of Fertility Matters Canada and in turn, all Canadian fertility patients. So we thank you for your ongoing support, not only of us as an organization and the support that we give to patients, but also of Canadian Infertility Awareness Week, which we're celebrating right now, April 19th to the 25th. So I'm not going to speak too long because I know you've got lots of information that we've got a lot of people that are looking for. So I'm going to hand it over to you, and what we'll do is I'll collect the questions as they start coming in. So if you're on Zoom, you can send your questions in the chat option. If you're on Facebook, just leave them in the comments of the video, and we will we'll get through all of those hopefully in our time here with Dr. Taylor.
Well,
I'll leave it up to you.
Yeah, thanks very much. I'm going to do this share my screen, and let's see how this goes. If there's any issues, I can just I'm just going to grant, I guess I didn't check this out that I have to grant access, but I'll do that now, and then we'll be able to get started, because we thought, you know, because it's Infertility Awareness Week, it makes sense to talk about general infertility talk, but because we're in the time of COVID, it also made sense for us to maybe do some specific ideas around treatment and trying to conceive in pregnancy during the time of COVID. This will not be a long talk. I'd like it to really be quite interactive.
Yeah, that'd be great. Did you find the share screen? There's a little button on the bottom. It's green.
I did, yeah, but now it's saying something about...
oh, it's going to give you all kinds of squares to pick?
I know, and I picked my keynote one, but and I'm just making sure it's letting. It's saying there's some sort of permission issue, so I apologize for that. We'll get working this now. Here we go.
Oh, there we go. We got it. Perfect.
Yeah. So sorry about that little delay. So I thought we'd talk about just getting started when you're infertile, and then talk about COVID, what it means for fertility, what it means for pregnancy, and what the current situation across Canada is during this pandemic. So just basics, I'm sure some people out there are just getting going and just realizing they're infertile, while others have done 5 IVF cycles and are looking at, you know, surrogacy and things. So there's going to be a spectrum, but I'll just start at the basics very, very briefly. But when a couple's trying to get pregnant, of course, you're having intercourse and the sperm is swimming up through the uterus, out the tubes. And then once a month, if you have a menstrual cycle every month-ish, an egg will be ovulated from the ovary, travel down the tube, and and hopefully that sperm will then fertilize the egg. The resulting embryo will travel back into the uterus and hopefully stick around, and you'll have a child 9 months later, 9-10 months later. So that's sort of the basic mechanics. And when a couple's trying to get pregnant, we recommend that they have intercourse every couple of days, starting around menstrual cycle day 10, assuming that you've got regular cycles. We don't advise you use lubricants. If you must use a lubricant, there's one called Pre-Seed, and there's another one on the market too that are sort of sperm friendly, and it's worth using those if you need them. There's no advantage to them. If they're marketed as if there's an advantage to them, there's not. There's just no disadvantage to them. So if you need a lubricant, that's something you could try. I also recommend, after you've been trying for a few months, to consider using urine ovulation predictor strips. And what those are, if you don't know, is the little strips you pee on. They look much like a pregnancy test strip. And you'd pee on them once a day, typically the second urine of the day. And you'll start around, same time when you're starting to have intercourse, around day 10 or 11, you'll start testing. And they should turn positive the day before ovulation. So knowing that they're negative test, and then they turn positive tells you, yeah, you're probably ovulating. There's a greater than 95% chance you're ovulating, which is very reassuring. If it never turns positive, it also tells you that you're not ovulating and you should get some help right away. Some people ask about basal body temperature, and a lot of people like to do basal body temperature. I generally don't recommend it because for a few reasons. One is it's finicky. So you have to take it before you've really moved when you wake up from your longest sleep of the day. So a shift worker, that might be 3 p.m., but for most people that's, 6 or 7 or 8 o'clock in the morning. When you wake up from your longest sleep, put a thermometer in your mouth and check your temperature and chart it. There's lots of apps that allow you to chart it. It's great, but it is a daily reminder that you're trying to get pregnant, which can add stress. And by the time it gives you useful information, i.e. the temperature rises, it tells you, oh gosh, I did ovulate, which is useful, but it tells you that you ovulated usually 2 days before the temperature rise. So it's too late to have intercourse at that point. You really needed to be monitoring in advance. So I usually don't encourage basal body temperature, but some people are really data driven and they'll like that idea. But for most people, I just say skip it. Use the ovulation predictor strips, or if that's stressful, just have intercourse every couple of days, and you should be getting pregnant. But if you're not, and it's been 6 months or a year for sure, then it's time to say, hey, you know what? It looks like I'm infertile. Let's get some testing. And that testing typically looks like a blood test on the woman for, and again, this is a very heteronormative talk I'm giving. I'm happy to talk about LGBTQ and single people as well. But right now, I think for this talk, the idea was sort of for a straight couple trying. For the female, she would draw an AMH level in her blood, FSH, and estrogen. That'll give you a good sense of your egg count. High egg count is good, low egg count is bad. Egg count drops with age. And as egg count drops, egg quality drops. So a lot of women who are 48, 49, and 50 still have eggs left. They're still ovulating, but the count is so low and the quality is so low that they're not getting pregnant typically at that age. So just so you know, a lot of women will say, okay, you've told me my egg count is low, but I'm still ovulating. Why am I not getting pregnant? And that generally relates to egg quality. So nevertheless, we get a sense of egg count, because egg count is going to tell us about how much time you have left and the quality of the eggs indirectly. Ovulation, it's useful to know if you're ovulating. You figure that out on your own with those urine tests. That's great. Otherwise, we'll often send people for a progesterone level done in the luteal phase, so after ovulation. Really valuable test is an HSG, hysterosalpingogram, and that's a dye test where typically a radiologist will put dye up into the uterus, flushes out the tubes, and an x-ray is taken. And that will tell us if the tubes are open, if the inside of the uterus is okay. And by the virtue of the fact that it flushes the tubes, it actually boosts fertility. So that's a very useful test. We'll find a lot of people will just get pregnant from an HSG. And then finally, a sperm test, a semen analysis. So that's kind of the panel we send people for. How it works at my center, Olive, is people get a referral and we say, okay, we send virtually everyone. Of course, it depends on the situation, but virtually everyone, certainly every straight couple who's trying to conceive, we would send them for this sort of a panel of tests. And then by the time you see the doctor a month later, 2 months later, we can go over all those test results and hopefully say something intelligent to you about why. And then those tests, I would say the tests determine the treatment. So based on the tests, we'll tell you what the issue is, hopefully, and we'll tell you what treatment to do. About 1 in 6 couples all the testing will be normal, and yet they're still not able to get pregnant. And so that's called unexplained infertility. And those people, we start to look at things a little bit in a little more depth to figure out if there's something that we've missed. And that's when we start to look for things like endometriosis or scarring inside that could be affecting you conceiving. And that requires laparoscopic surgery to explore further. So we kind of go case by case, do a history, examine the patient, and kind of figure out if maybe endometriosis or scar tissue is the issue, and make a plan from there. So once you've got your tests done, then you'll need to talk to your doctor. And during the time of COVID, for most people, seeing a fertility doctor in the country, that's going to be by phone or by Skype or FaceTime or something like that, because we're not meant to have one-on-one visits to minimize the spread of COVID. So, but we are encouraged to, continue providing care to people. And so we're doing that through phone and through sort of telehealth video conferencing. And when you talk to your doctor, that's again, when all those tests will be reviewed. They'll decide if maybe additional testing is needed. Maybe you need surgery. Maybe you have a fibroid in your uterus we've found, or a polyp, or maybe you need your tube operated on to fix it. Sometimes we'll find a hormone imbalance that we'll give you hormone medications for, like a thyroid or a prolactin issue. And sometimes we'll be looking at sperm and saying, hey, this is what we can do to improve sperm. So we'll based on what the tests show, we'll give you some treatment advice. And the kind of treatments that we do include fertility medications, include insemination, include IVF, and sort of some cocktail of or mixture of those is generally what we do, and surgery if needed. So for fertility medications, Clomid, everyone knows about Clomid because it's been around since the 50s. It is still available. I'll try to preempt that question. Clomid is still available, but you have to get it from a pharmacy that can compound it, so have to make it themselves. So the main manufacturers stopped making Clomid a couple of years ago now. So we have it in our pharmacy. A lot of fertility clinics will have it in their pharmacy, and compounding pharmacies across the country can make Clomid for you, clomiphene or Clomid for you. Letrozole is sort of the sister drug to Clomid. It was developed in it's been around a long time, but it was originally a breast cancer treatment that realized that it actually made people a little more fertile and works much like Clomid, and is widely available because it is found to be effective for breast cancer. So we use it as an off-label medication in fertility. So both letrozole and Clomid, you should consider virtually identical medications. And they're not all that expensive, maybe $80 or $90 for 1 month treatment with these medications. And what they do is they make you ovulate if you're not ovulating. And if you're already ovulating, they'll make you ovulate 2 or 3 eggs instead of just 1. So it boosts your fertility by increasing the number of eggs that you would release. The other way we can boost the number of eggs a person is releasing is through giving them hormone injections, so FSH injections. And there's other things too. Sometimes we'll be treating people with just progesterone is all they need. Their progesterone's a little low. Give them a little bit and they'll conceive. And same with bromocriptine if they've got a prolactin issue. So we'll try to tailor it to what medication you might need. I'll highlight the last line on this slide. I think virtually every woman should be taking these 3 supplements if she wants to get pregnant with her eggs. And that's a prenatal vitamin, coenzyme Q10, and vitamin D. And the first one, of course, is for the health of the baby. And the latter 2, the CoQ10 and vitamin D, are to promote egg health. So there'll be other, naturopaths and other fertility physicians will have a slightly different cocktail. That's my cocktail. And then I add additional things based on blood testing in the clinical situation. Sometimes we put people on metformin or inositol or melatonin if they're not great sleepers. So we personalize what supplements might make sense for a woman. But really, I think everyone at the baseline should be taking something like a prenatal CoQ10 and vitamin D. Now, I mentioned that those 2 fertility pills are designed to increase the number of eggs released from the ovaries. When you're releasing those eggs, it would sure be a great idea if there was more sperm getting to those eggs. So we can do that through insemination. And insemination is helpful for men who have a low sperm count or low sperm swimming, or even men with good counts when we're worried about the cervix as a barrier to the sperm getting to the tubes. And in general, helping even guys with normal sperm get more sperm up to the eggs, you're more likely to be able to conceive. And that's called insemination or intrauterine insemination. It's done once a month on the day of ovulation. And the cost it varies by clinic. We charge $650 for an insemination. And it's done once during the menstrual cycle on the day of ovulation. So as sort of a replacement to intercourse that day. Other treatment that everyone knows about is in vitro or IVF. And what's involved there is that you take fertility injections to grow multiple eggs. Those eggs are then extracted through the vagina. We go in with a needle and we extract those eggs. And then we fertilize the eggs with sperm. And those fertilized eggs are now called an embryo. And then the embryo grows and divides and divides and divides, typically for 5 or 6, nowadays even 7 days in the lab. And then that embryo is usable. You can put it right into the woman right away. That's called a fresh embryo transfer. Or you can freeze it and put it in later. And the third option is you can test it, then freeze it and put it in later. At our center, 85% of our transfers are frozen. We don't do very many fresh embryo transfers anymore because in general, frozen embryo transfers have higher pregnancy rates. Women under 35, it's pretty close. Fresh is pretty good still. But in general, frozen has a bit higher pregnancy rate than fresh embryo transfer. So that's IVF. IVF, it costs about $10,000. And then also on top of that, you pay for your medications. And if you opt to test your embryos, that could add another $2,000 or $3,000 as well. So it is not cheap to do IVF. But for most couples, IVF is quite successful. I know there's lots of stories out there where IVF didn't work, but particularly for women under the age of 40, generally speaking, IVF is more likely to work than not. Of course, it depends on the situation, for sure. So this is, I was just touching on here with this slide. I'll skip past it really. It's just showing that level. That's what an advanced embryo that we can test and we can freeze and we can transfer looks like. It's called a blastocyst there on the bottom right. And what we do if we're going to biopsy a blastocyst to see if it's normal, carries a gene, has a chromosome problem or not, is we're biopsying those darker blue cells around the rim. The epiblast is the baby, and the blastocyst, that shell, is called the trophectoderm, and that's actually what we're biopsying. So we're not biopsying the baby when we do these tests. We're biopsying what will eventually become the placenta. All right, so blastocyst embryos can be biopsied, and if you're testing, just so people know the semantics, if you're testing for a chromosome issue, it's called PGT, and usually there's a -A at the end of that. I should have added that, PGT. And then if you're looking for a single gene disorder, it's often called PGD. So you're looking for a single gene disorder that you're trying to diagnose. Some centers will call this PGT, they'll call it PGS. We used to call it CCS. Nowadays, the convention is everyone's meant to call it PGT-A if they're testing for chromosomes, because that means aneuploidy. And then if it's PGT-SR, if it's a structural relocation, and M if it's a monogenic disorder. But anyway, just the semantics, we're talking about PGT and embryo testing, but I don't want to go down that rabbit hole like I've already gone. Okay, so now we have embryos. And they can be transferred back into your uterus, or they can be transferred into a surrogate or a gestational carrier if you need one. I talk fast. And but I am open to questions, but maybe I'll just finish. I only have a few more slides, and then maybe we can just have a broader discussion if everyone's okay with that idea.
I think that would be great. So
COVID-19, what do we know about it? Well, you know, it's amazing how much is being studied and being shared around the world. There's a massive scientific collaboration happening right now with COVID. We're getting reports out of China. New York City's been publishing a lot of their experience with COVID in fertility and in pregnancy. And I'll just summarize by saying so far it looks quite reassuring. So it does not seem that a COVID infection in pregnancy causes miscarriage. It doesn't seem to harm your reproductive system in any way. And so it doesn't seem to impact fertility. And in fact, even if you catch it in pregnancy, as I say, it doesn't seem to affect the fetus. And although we all agree a severe lung infection in pregnancy is a terrible thing, and generally more severe than other women, the New York experience is that pregnant women are similarly sick to non-pregnant women, even if they get it in the third trimester. So really, so far, it's been quite reassuring on the COVID in pregnancy front. But again, this data is just emerging over the last few months. And so we'll see when we have bigger and bigger numbers. Certainly you would not want to get COVID in the first trimester of pregnancy, because we know significant illnesses with a high fever, a major illness in the first trimester of pregnancy does increase your risk of miscarriage. Though they have not yet sort of documented that, but that's what we understand so far. So I think really reassuring. But there are still some unknowns because we don't have a lot of people that we've had reported on, and certainly in BC, I'd have to look up the numbers, but I think there's only a couple of women who have tested positive for COVID in pregnancy, and it's gone well. So thank goodness. I think we'll look back at this and say, oh, it was much like the flu, it's just a severe flu for women in pregnancy. Now, people are asking this a lot. Every day we're getting questions about, okay, so what, can I get my testing done now? And the short answer is yes, you can get your testing done. Certainly blood work and sperm testing is available. It's a little harder. So because now testing centers are spacing out visits more, they're restricting their hours a bit. So it is a little bit harder to get blood work and sperm testing than before, but it is still happening. So persist in trying to get your testing done. HSGs, at least I can speak to BC, are getting really difficult to get. They were always a little hard to get. It always took a month or two to get in for an HSG to check your tubes. But now it's getting even harder because generally it's done at the hospital by radiologists or at a radiology center, and they've all been shut down or no longer offering that service during the pandemic. Here in BC, we're starting to see things open up. I think maybe by May, June, we'll see that open up and improve access to HSGs. But HSGs right now are the single hardest test to get. But again, it's a good test, and so it's worth waiting and trying to get that test. When will things return to normal? Well, that really varies province by province. BC, prairies, and the maritime provinces, it seems like the curve really is kind of flattening and starting to go down. A little less so in Quebec. Ontario's looking good, looking better too. So it is kind of varying a little bit by province. But all the provinces still are being very cautious and not reopening many things yet. So because we've been able to flatten the curve really well, we anticipate that it will be safe to start offering some services in May or June. And so at Olive, we are planning with nearly daily meetings about reopening in sometime sort of mid-May to start IVF cycles. So that's our anticipated start date is in mid-May. And we're going to be starting sort of slowly. So we're going to start with IVF because it's no pregnancies involved in that. And we don't want to offer all the services right away, because what if COVID reemerges and we have to cancel things? We're starting with treatments that are quite quick to do and sort of minimal risk to patients. We're going to minimize the number of patient visits and but still be able to help people. So I think if you're planning to do IVF, you should expect to be starting in May or June if you're hoping to do it. Inseminations, I think, will probably be confidently in July, perhaps even in June. We can open for that. We are following the guidance of lots of people, the provincial health authorities, the government, of course, who as they tell us whether we can reopen, and the Canadian Fertility Society. That's a major one who we're really, following their lead and giving them input in when and how things can reopen and what's the safest way to reopen. There's no right answer. I think every clinic's going to do it a little bit differently, but we're all kind of working towards a new model. And I think the new model will look like when you go to fertility clinic now, at least for the next several months, it will look quite different. First off, you'll probably have only spoken to your physician by phone to start. When you get into treatment, you won't go into the waiting room like so many people have done and see 30 people sitting in the waiting room. You'll now go into a waiting room and there'll be fewer people. The staff will be wearing masks. They'll be wearing gloves. Some clinics I know are going to insist on all patients wear masks. You probably will be asked not to bring a partner or a child if you have one to the clinic. And the appointments will be staggered throughout the day rather than everyone come in the morning and we'll do everyone's blood work all at once. We'll have that sort of thing staggered out. So it'll look a bit different when you go to a fertility clinic for the next little while. But if you look at, at least I've looked at BC, of course, but also if you look at many other provinces, fertility is still considered somewhat an essential service. It's on the list of essential services. Now, I think out of, abundance of caution, most clinics shut, recognizing that we're not a life and death service. But now that things are looking so good and we realize that, this is a real problem for people, that we're starting to open up. So I know there's a lot of people wondering, well, why can't I do an IUI and things, but I think it's just that gradual reopening, probably full reopening in July. is kind of a cautious approach and just introducing some services now and introducing more and more as we go along. But so there'll be that transition between May and July. So I'm going to answer some questions now. I'd be happy to do that if they come verbally or on the chat line there. Also, do not hesitate to email me. Happy to answer an email. I usually do so within a day or two. You can also call, even if you're in New Brunswick or whatnot, you just want to talk to someone, you can call one of our nurses. You can send us a message through Facebook, though I'm much better at getting back to people by email than I am checking the messages on Facebook. But we do probably a couple times a week go onto Facebook and see if there's anyone that's messaged us. But email is the best way to ask a question. And then if you're looking for what's the current status of fertility in Canada, like what's in terms of clinics opening, you'd look at the CFAS website, and they gave a guideline a week ago, and I know there's a new one coming out probably early next week that will kind of give some more guidance to clinics about reopening. So that's another place to look, and of course Facebook has always got gossipy chat rooms too. They're often quite accurate. So keep abreast of social media too.
That's great. Thank you, Beth, for that. If you want to unshare your screen, then you and I can chat, because we've got a ton of questions that have come in for you.
Okay, great.
And I'll ask them so that you don't have to worry about digging around in the chat line there. So thanks for that presentation. That was really great. So we've got questions, lots about fertility, some about the COVID stuff. So I'm just going to work my way through, if that's okay with you. What's a good egg count for AMH?
Excellent question. So that answer depends on your age. She probably didn't put her age in that question, but higher the AMH, the better. AMH is measured in picomoles in general. Most labs measure it in picomoles. Some labs measure it in nanograms. And you do, believe it or not, most people like to ignore high school chemistry, but you do need to know the unit, because patients will contact me. They will be freaking out that they have this AMH of 2, and because they understand the picomole units. 2 is a terrible AMH in picomoles, but theirs is nanograms, which is actually pretty good. So you do need to know the unit. I hate to say that, and it's going to vary province by province. In BC, we get reports from both, so it's a bit confusing. But for picomoles, which is the most common one, the range they will put on the report is between 3 and 50. You should be happy, really, at any age if your AMH is above 20. If you're in your 40s, you should be happy if it's between, if it's above 10. You should be happy if it's below 10 at any age in picomoles. You'd start to feel anxious that your egg count is low.
Great. Okay. I hope that answers. It would answer it for me. So hopefully, thanks for giving the ages, because then they can figure that out on their side. Would the ovulation strips for LH Surge help with a woman with PCOS on oral fertility meds, Provera or Femera cycles?
Okay, so Femera is letrozole, folks, if for those who don't know. So Femera is letrozole. It's the brand name of letrozole. Okay, and that is a good question. So the urine test strips are looking for the LH Surge, okay? And they're looking for an LH Surge for an LH above 20. So if your LH is above 20, the urine test strip, for most of the brands, will turn positive and say, yep, that's an LH Surge. You're ovulating tomorrow. And for 90% of people, great. LH above 20 means you're ovulating. Severe PCOs can have an LH that's high. So they can have a LH on their own that's 22, 23, 25, and so they will trick the tests into saying that it's positive, but they're not. So that's why I often ask people, if tell me they've been using those strips, I say, is it positive every day? Like, does it go negative and then turn positive? Because that's critical. So it depends. If you've got PCO and you're on Femera, give it a go with an LH strip. It will, if it starts out on day 10 or 11 as negative, and then it's negative and negative, and then it goes strongly positive one day, and sometimes it's 2 days positive, but a couple of days strongly positive, you're probably ovulating because you went from negative to positive. But if you're weekly positive every day and it's maybe a little stronger one day and you have PCO, you're probably not ovulating. And those people, in normal times, we bring them in and we instead monitor their blood. So we'll say, oh God, look, this is one of these ones that runs high LH is not a problem. We'll see, oh, she's got a 20 today, 20, 20, 20, and then it'll go to 70 and we'll go, oh, okay, now but that woman in her urine will be positive every day, but we will see that rise in the blood. So those people generally need blood testing.
Okay, great. Thank you for that. What are the parameters for semen morphology that would require IVF?
Semen morphology. That's I mean, at least in BC, and I don't know what province the question comes from, but in BC, morphology is a nightmare. So let me just so that everyone knows, probably you do, but when they do a sperm test, they look at how many sperm you have and how well they swim. That's called motility. And then they look at the shape of the sperm and they say, hey, does this sperm look like the normal shape, the normal shape? And they give a percentage of normal, okay? And they'll say it's 5%, it's 15%, it's 2% normal. They'll give a percentage of the sperm that look normal, and that's called your morphology result. Morphology is very subjective, and the criteria by which you judge what is normal is ridiculously strict here in BC. So you won't find a guy, even the guy that's got 4 kids in your neighborhood, with a morphology that's much better than about 15 or 20. Fertile guys, and that study's been done out of our big maternity center here, looked at fertile men whose wives just gave birth, looked at their morphology, and they all had crummy morphologies. So don't panic about morphology, especially if you're in BC. Most guys will have sort of between 3, 4, 5, 6, 7% normal forms, and probably it doesn't matter. The guys where I worry about morphology, though, are the ones where they're infertile and they're coming in with persistently 0s and 1s over a few tests. And you go, gosh, you know what? There's something going on here that isn't right. Because, sometimes you'll get a 1 and then the next time you test him, he has a 5 and you're like, well, probably it's all fine. But if you get a persistently 0, persistently 1, persistently 2, then
is that in percentage, a 0, 1, 2%?
Yeah, sorry, 0%, 1%, 2%. If you get those and they're persistently low like that, you do start to wonder about that contribution, and those guys often end up doing IVF.
Okay. And this is not in the question, it's just my own thinking, does sperm count affect, if they have a high count with low morphology or a low count with low morphology, do those correlate, or is there, does it matter?
Really, but it is quite good. Like if you've got a really high sperm count and only 2% of your sperm are normal, well, you still got a lot of sperm then. But if you have a low sperm count and only 2% are normal, well, then that's not very many good sperm. So yeah, count does matter. It doesn't always correlate, but it does matter.
Okay, thank you for that. Is there a prenatal vitamin is there one prenatal vitamin that's better than the others, or are they created pretty much equal? I don't know if that's something you can answer.
Yeah, well, the prenatal vitamins are, honestly, they're all, created equal in my mind. We know that folic acid dramatically improves the chances that you have a baby without a heart defect and without a neural tube defect. So you should make sure you're getting at least 1 milligram of folic acid, and all the prenatals will have that. They usually have 0.4 to 1 milligram. And I don't really think that there's a difference between the different brands.
Great, thank you. How long do you have to wait to transfer if you test the embryo? So I guess if you do PGT,
right?
What would be the wait time there? That's a good question.
Yeah, that is. And it's actually not different than if you just froze the embryo.
Okay.
So you create the embryo. So you have your egg extraction, we create the embryo, we test it, and then you're going to have a period a few days later. And then from that period, you'll start your medicines to get into the frozen transfer. While you're on those medicines waiting to do that transfer, we will get the results of the PGT and we can do the transfer that month. So frozen or not, with your next menstrual cycle, you can have a transfer.
Wow, that's great.
Yeah. Now, I will say one thing, I'll just jump in and say, a lot of times nowadays, we are getting a normal embryo, and a lot of our patients are over 35, so they're not getting a lot of normal embryos, and we will actually pause on doing a transfer and spend some time doing endometrial receptivity testing at that point. So you'll do your IVF 1 month, the next month you'll do endometrial receptivity testing, and then next month do the transfer. So
you want to just kind of make a note of what the receptivity testing is or what it's for? Because there might be people that don't know
Yeah,
what
it's
that
fairly
is.
new, right? It's fairly new, but we're pretty impressed with it. We've published some data on showing the benefit of it. What it is when when a woman takes the medicines getting ready for an embryo transfer, those medicines are designed to make that lining, the uterus, sticky and want to grab onto the embryo and hold onto it. And we know some women, to make their lining sticky, they need more progesterone or less progesterone or a higher dose or a different frequency or duration of progesterone. And so most women don't. Most women need the standard cocktail, but about 15% of women actually need something a little different. And we can figure out if you're the one who needs something a little different with that endometrial receptivity testing, or ERA, endometrial receptivity analysis. And so we're quite keen to do, especially in people with low embryo numbers. It's worth thinking about before these embryos just cost you thousands of dollars. Wouldn't it be nice to know for sure that you've got a sticky uterus to put it in?
Yeah, that's great. And as you see, we see it popping up, the questions popping up in our support groups a lot now.
Yep.
Over the past couple of years. So thank you for addressing that. If more cases surge up after fertility clinics open, so this one's about COVID, will they close up again? Will IUI embryo transfers be done?
Yeah, good question. And you do wonder whether, as they loosen up these guidelines, whether we are going to get a resurgence of it. Which is why when we reopen, we're trying to do it in a way that would allow us to stay open, even if there was another big lockdown, because we were deemed essential. So technically we did not have to close. We closed sort of out of a caution and to protect staff and patients and all the like. But if we reopen in a really, really responsible way, where, there's no two patients within 2 meters apart, everyone's got a mask down and glove on, that maybe we think, certainly we're hoping we could stay open through another, rise in COVID cases. Depends how big that rise is, though. So there's always that risk to get a massive rise, in which case we would shut down again. It's hard to know.
It's very hard to know. But I've been hearing that from several specialists this week. They're making precautions very similar to yours. I know that you're working with the CFAS to figure out, how do we make this work so everybody's safe. So thank you for your attention to that, because I know the patients will be happy to know that, work is being done in the background to make sure this can happen.
Yeah, a lot of work.
Is there any way, this is back to the clinical side, is there any way to slow down endometriosis? I have had 6 surgeries in the last 10 years. I just had my 6th surgery at the end of February and would love any tips.
Okay. You can absolutely slow down endometriosis without surgery. The problem is all the ways you slow down endometriosis prevent pregnancy. So a Mirena IUD, progesterone injections, oral progesterone, Lupron shots. There's lots of different ways you can suppress endometriosis and keep it at bay. But unfortunately, when you suppress endometriosis, you suppress fertility. So there isn't. So I say, if someone just had fertility, surgery for endometriosis and they're hoping to get pregnant, rush, get going as fast as you can. Think about even being aggressive, like doing IVF sooner than later, and get embryos banked. Because we know that endometriosis marches on, erodes the ovaries, damages the eggs. Like, get on it right away. Like, that's one group of people that just 6 endometriosis surgeries, like, get on it. And if you can, and get some embryos stored before that endometriosis comes back.
Yeah, that's great advice. Another question. I'm a patient of Olive in Surrey. I have PCOS and am not regular. We were able to get pregnant on our 2nd try in November with IUI, LET and FSH injections, letrozole, yes. We lost a baby due to chromosome 15 in January. I was wondering if this could be genetic. And also, I just got another text. Is that one? So I'll leave it at that. There was another piece to that, but I'll get back to it.
Okay, so not genetic. Chromosome 15, having an extra chromosome 15 in a miscarriage is random, terrible luck. When eggs and sperm come together and make an embryo, there can be mistakes. And the mistakes are things like extra chromosomes, and chromosome 15 is not an uncommon mistake. Chromosome 15, chromosome 16, chromosome 2, those are ones that are a bit fragile somehow, and they're more likely to end up with a mistake in the number. And then you miscarry those. You're meant to miscarry those. There is no human who's lived with chromosome 15 addition in history. So those are meant to miscarry. I actually kind of like hearing that when you have a miscarriage, as hard as it is. I've had miscarriages myself. I know it's kind of nice to know it was a chromosome problem. That just means it was bad luck. Keep trying. You can't really do much to prevent that. You know, the CoQ10, maybe, the vitamin D, maybe, because they help in that process when eggs and sperm come together and trying to help increase the chances that a fusion happens properly. But I'm glad you got pregnant in November, and get back on the letrozole and do the same thing again. And as soon as we can get going, for you, that'll probably be late June or July. And keep trying at it, because you've gotten pregnant now, so that's a very good sign.
That's bad a very good sign.
I don't mean to sound glib or dismissive, but that was bad luck, and you know, rarely does bad luck like that happen repeatedly. So hopefully you'll find success.
Oh, that would be great. This is a great one. Can the blastocysts still be biopsied if they've already been frozen?
Yeah.
So I guess after being frozen.
Like every question I answer, I can make a short story long. The short story is yes, absolutely. Thaw them out, biopsy them again. The long story is I don't like it. You'll find people will do that. I don't like that unless you're going in after a newly identified genetic disorder or something like that. I think you should just, you know, not go in after and biopsy them. It's pretty hard on an embryo to be biopsied, frozen, thawed, biopsied, frozen, thawed for a transfer. And we have babies at Olive from that. We have healthy, beautiful babies from doing that. But there's little doubt, and there's some evidence too from bigger studies showing that there is a decrease in the chance of a pregnancy. So you better to just do a transfer, maybe do a double embryo transfer of untested embryos than actually thawing them out and testing them.
Yeah, that sounds like it could be really risky.
Yeah. And
probably a very individual choice. Yeah. Are all IVFs done for over 35? Do have to be from frozen, or can they be fresh? So I guess over 35 years of age. Yeah.
Look, you know what I always say to people, these are your embryos. We'll put them in fresh if you want us to. Well, we'll just show you the data. And most people over 35, when they see the data, they go, oh God, it's, you know, 10, 15, 20% less if I put it in fresh. So for most people, when they see the data, they ask for frozen, but they're your embryos. We're happy to put them in fresh. It's less work for us if you put them in fresh. So we're happy to do it, but we generally don't recommend it because usually pregnancy rates are higher. Now, patients, I'll now say the same thing in the opposite way. If you have a baby, you did IVF with us a couple of years ago, you had a baby from a fresh embryo transfer, I will encourage you to do another fresh embryo transfer. And the reason for that is that perhaps there was something about the environment in a fresh transfer that actually was good for you in your specific case. But in general, we do frozens over 35.
Great. That's really good. And I feel like I'm hearing more and more that clinics are moving to do freeze-all and moving away from these fresh cycles because of that data specifically. Yeah. That's good for patients because we do hear that a lot. There's a lot of confusion or questions about why, you know, they feel like I want to do this fresh cycle. I really want to, and my doctors are encouraging me to do a frozen, but when you see the data and the success rates of the pregnancy rates with live birth after a frozen, I think that that's a pretty positive outcome.
Yeah, I know. And it's a real struggle because people come, by the time people get to IVF, they are like broken, scared, anxious, emotional. They want to be pregnant tomorrow. They don't want to freeze their embryos and then wait another month because everything that goes in your freezer at home is worse when it comes out, but it's not true of embryos. And I know you want to be pregnant like tomorrow, but if you could just wait another month, we can get more likely to get you the baby you want, you know, but it's, yeah, it's not easy.
This is from one of your patients. We don't have a name. I'm almost 38. My AMH was 36 in February 2019. And following my miscarriage in October 2019, my February 2020 AMH is about 21, which has me concerned because now my AMH is low. What should I do to boost it? Is that possible?
Yeah, fair enough. I will say, and this is true of any blood test, if you do the same blood test every day for a week, it'll never be the same number twice. So there always is some fluctuation. So 36 might have been, anywhere from 32 to 38 or something, like there is some fluctuation. So, and 21 might have been 25, but it is a drop. No matter how you slice it, that is a drop in AMH. And it does raise a concern that, especially if it was done at the same lab, it raises a concern that your egg count's dropping. You see this in women, like kind of going through that, transition from like 35, 36, 37, you start to see that AMH drop a little fast. Some of the rate is genetically determined. And so if you've got your mom telling you, hey, I had menopause at 44, and you now have this sudden drop, that's kind of should maybe push you to be a little more aggressive. I know it's always easy to say be more aggressive, but probably that's the time when you go, hey, wait now, there's a sign. I have this information for a reason. Why don't I use that information? I was told my eggs are dropping quickly, maybe a little more quicker than average. So let's get on it. Now I will say the other thing too is, and to dig a little deeper, is sometimes if people are on hormones, the AMH will be artificially low. So you kind of got, if you were really not on any medication and you did 2 AMHs and there was a drop, you should sort of say, hey, that's a concern. There's nothing you can do to increase your egg count. So you really just have to act and try to get into some treatment.
Yeah. Thank you for that. I feel like there's so many patients getting a lot of really amazing information right now. I'm learning so much. That's why I love doing these sessions. And we've had over 30 questions come in, so there's no way we'll get to all of them tonight, but we'll work out a way to get the questions answered from Dr. Taylor for all of you. What would you suggest for someone with irregular periods and constant spotting?
Irregular periods and constant spotting, to me, immediately my gut reaction is not ovulating. So I would, if you're not ovulating, I'd put you on letrozole and monitor you for your LH. We usually monitor with blood and ultrasound and just figure out, yeah, now we got you ovulating. And that should fix the constant spotting and the irregular periods. If it doesn't, we'd look at other reasons that you might have spotting. Do you have an infection in your uterus? Do you have endometriosis? Are you low in progesterone? Is there some other reason you constant spotting? But the first thing you'd want to fix is the irregular periods, because usually everything else falls from there.
Well, that's really interesting. What are your best tips to prepare for an FET? I've never done it before and I only have 1 embryo.
Okay. Never done it before, 1 embryo, you may want to think about ERA, that what I talked about earlier, that endometrial receptivity analysis. If you've got 1 precious embryo, you may want to think about that. Other things to prepare, of course, keep your weight down. If you're overweight, bring your weight down. Do what you can to try to optimize your chances of success. If you're over 40, you probably want to take low-dose aspirin. You'll take your prenatal for the baby. Make sure that your doctor has checked your thyroid recently. Make sure that's in the normal range. Kind of optimize your health. Weight down, thyroid perfect. Endometrial receptivity testing if you can access it or if it makes sense, and then get into the transfer.
That's awesome. And I feel like being in the time of COVID, in this sort of waiting period, it's a great time for patients to get in control or feel like they're moving. These are things that we can do in this waiting period before the doors open at the clinics to get into these more optimal or balanced states, so that when the doors do open and your call for your treatment is to start, you're in that your body is ready.
I totally agree. If I can add one more thing to that, acupuncture. I'm a, Western medicine, nerdy science, evidence-based kind of doc. So I generally don't tell my patients to spend the money or time on acupuncture. Embryo transfer is the time that I sort of open that I suggest that, because there is some decent Western medicine studies that show there may be a benefit to acupuncture. Whether it's the acupuncture itself or the reduction in stress that we see in people who have that sort of treatment around embryo transfer, I'm not sure. but there is some suggestion that acupuncture may be beneficial at an embryo transfer. So for the lady who asked about, you know, got one precious embryo, you know, if you can afford it, doing acupuncture might be another thing to consider. And I should bring that up.
That's a great suggestion. If IVF fails multiple times with one clinic or doctor, is it worth going somewhere else to get a second opinion?
Yeah, I think so. You know, if you do a couple of IVF cycles, and when I say IVF cycle, I mean stimulation with injections and egg retrieval. If you do a couple of egg retrievals at one center and you have had no luck, like not a baby, it's worth going and getting another opinion. And I tell my patients that too. Like, you know, I mean, if you've come to me and you've done a couple IVF cycles or 3, and I haven't given you a baby, it's either because it's not, you actually can't get a baby, or it's that, you know, there's something wrong with the chemistry here, and go somewhere else. I like it when people get a second opinion because, and I say that with tons of arrogance, usually they agree with me. And I think people are reassured by hearing that, like, yeah, 2 experts kind of say the same thing. You know, we put all our eggs in the Dr. Taylor basket. What if she's a quack and totally wrong? Like, if I hear it from someone else, then they get reassured. They come back. They usually come back and they feel more confident that, you know, I'm giving them the best advice that's out there and things. So yeah, get a second opinion. There's no, you know, in Canada, we're so fortunate. It's there's waits in Canada, but you know, generally second opinions are covered by the health plan, or go to the US and get a second opinion. And yeah, it's worth doing because you want to have peace of mind that, you know, if you've got a couple failed IVF cycles, that you did everything you could. So yeah, happy to encourage that.
That's great advice. Thank you for that. Is the statistic for success in a donor embryo the same as a biological embryo?
Okay, that's a good one, and it's hard. I'm not sure how to answer that really because generally donors are women in their 20s. Usually biologic embryos, most of our patients are over 30. So in that case, a donor embryo is better because it's younger. But I think maybe your question is more like, if you had a donor embryo that was tested and chromosomally normal, and you had an embryo of your own egg that was tested and chromosomally normal, no, they're the same pregnancy rate. Yeah.
Great. That's good to know. That's a really good question. I haven't seen that come up before, so that's good to have that answer. I'm just going to go, we're going to take one more question. I just want to make sure I'm clicking through them all here. How many cycles should a person continue with Provera or Letrozole before exploring IUI or IVF?
Oh yeah, so that's a good one. So Provera, you shouldn't need Provera. You shouldn't need Provera after like the first go around, because if you're on if Letrozole's working for you, you'll ovulate and make your own progesterone. You shouldn't need Provera. So Provera is something you take once or twice to kickstart the period so that you can do a Letrozole treatment. You'll need it again if the Letrozole didn't make you ovulate. You'll need Provera again, but it shouldn't be long term. Like, you shouldn't need Provera very often. But to try to answer the question, if you've done 3, you know, depends on your age a bit too, right? If you're 41, then you should probably think about IVF sooner. If you're 32, then you got a good egg count, and you've done 3 Letrozole cycles with Intercourse and you're not pregnant, I think at the 3 or 4 mark, you think about adding insemination.
Great. So we do have more questions, but just in the interest of time, we're going to, I'm going to pause the questions, and what we will do is get those questions to Dr. Taylor, and we'll figure out how to get them answered for everybody. This session was incredibly informative. I hope that everybody watching, I'm sure with the questions that were coming in and your answers, and then seeing in the chat, thank you so much. I feel so much better. Thank you for sharing your expertise and your time. Lots of people very happy with this information session. So thank you for being here with us.
Oh, my pleasure. It's nice to connect to people in this way.
It's so nice. So for everybody who's tuned in, we had a good 70 to 80 people live with us tonight. So that was amazing. And of course, if you're watching the replay, or if you tuned in late, this video will be made available on the Fertility Matters Canada Facebook page, and within the week on our YouTube channel. So please make sure you check back for that. If you need to get in touch with Dr. Taylor and you're interested in information, we will connect you with Olive Fertility. So you can look them up on Facebook. They're very easy to connect with. On behalf of Fertility Matters Canada, the Board of Directors, and all the patients that we support across this country, Dr. Taylor, thank you for your time. Don't forget, it's Canadian Infertility Awareness Week, the 19th to the 25th of April, and we've got these live events happening with fertility experts from across the country for you live all week. So don't forget to tune in Friday. What's today? Thursday and Friday and Saturday. We've got tons of sessions. All of the events are listed on our Facebook page and on our website. Thank you so much, and we hope everybody has a great evening. We'll see you soon. Bye.
Bye-bye.